I think we can get started. I know some more folks will be joining, but I want to make sure that our speaker has plenty of time for her talk and that we have plenty of time for questions afterward. Welcome everyone to Geriatric Medicine Grand Rounds. I'm really glad you can join us this morning. We have a fantastic speaker from Rush University who is going to talk to us about a really exciting and important program. Diane Mariani is the program manager for Caring for the Caregivers. She's based at Rush, which has really been a leader in age-friendly transformation, and I look to them for resources and have been really impressed with all the work they're doing to advance age-friendly. And of course, all of us know that it's so important to support caregivers, particularly for those living with dementia. It's something near and dear to all of our hearts and something that that we see the importance of in our day-to-day practice. So I'm so glad that you've come to tell us about your work, Diane. Thank you. Thank you so much. And please go ahead and share more introduction and go ahead and get started.
Great. Thank you so much, Kate. I'm just thrilled to be here with you all today. Thank you for having me. I am here to talk about caring for caregivers, and I was mentioning to Kate earlier that this is a topic that's just very near and dear to my heart. I don't often do this, but I'm going to go ahead and disclose that I'm also a caregiver. So I'm a caregiver personally, and then professionally, I am invested in this work. Uh, so Rush University Medical Center in Chicago, many of you are aware, we are an age-friendly health system committed to care excellence for older adults. And our program, Caring for Caregivers, really was developed in 2019 through a grant from the RRF Foundation for Aging. So they funded us to kind of really create this model and address the concerns of caregivers. And then, of course, we spent some time just really kind of fine-tuning the model and learning a lot as we were implementing it. And then the John A. Hartford Foundation funded us to pilot test our model in 6 age-friendly health systems. And we did that very successfully. And then because of that pilot test, we then were refunded by the John A. Hartford Foundation to then share this model with age-friendly health systems, area agencies on aging, and other interested parties across the country. So our learning objective today are here on the screen. I won't read them for you, but this is what we'll be talking about today. So becoming a caregiver. I'm sure many of us know that becoming a caregiver really can happen in a variety of ways, right? It can happen over a period of time, kind of gradually. It can happen very quickly, like after a crisis kind of situation. And it can also kind of go back and forth. Maybe you care for a while during a situation, a medical situation, and then, care is not needed at a certain point. So it's just a variety of ways that people are caring for older adults. And it's important to note that many of us are not prepared to be a caregiver or anticipate being a caregiver because it can happen very suddenly. But even if it happens over time, just really we're not really thinking in those terms and planning ahead of what that would look like. Oops. So some of the common challenges for caregivers, you might be surprised to see this statistic. I was when I first saw it. The clinically significant signs of depressive disorder are present in 40 to 70% of family caregivers. Additionally, 40% are experiencing 2 or more chronic diseases. So it's clear that, providing care can have a physical and emotional impact on us. Additionally, I think one of the things that we're really finally coming to terms with, those of us that have been working in this area and, spreading the word and really understanding what caregivers are dealing with. About 58% of them are engaging in medical and nursing tasks. And of course, we know most of us are not skilled in those areas. We don't have that, we just don't have those skill sets. And additionally, even if we have some knowledge of it, because I speak to a lot of medical professionals that are also providing care for family members, and even though they may have a role of, say, a nurse, once it's caring for their own family member, it just changes the dynamic completely because your emotions are really involved. And it's just really different than when you're just working with your patients. A lot of caregivers are administering medications, sometimes just so many. They're doing wound care, they're handling complex medical equipment in the home. Sometimes it's IV medications. I had to do that myself for my father when he had with his cancer diagnosis. And I still recall when the home health nurse came in to kind of instruct me, I was really paying attention very closely, very diligently, and watching what she was doing. And kind of was like, okay, got it. The next day when I had to do it myself, I was so discombobulated and so fearful that I was going to do it wrong and harm him. I literally felt like I didn't know what the steps were. So I had to make a phone call, so it's one of those things where emotions are high and it's a big responsibility if you're not really trained in these areas. And despite this, we're rarely asking caregivers, are you ready, willing, and able to provide this care? Additionally, social isolation is also a factor for many caregivers. I would say a lot of times it's for those more intense caregiving situations, perhaps like with somebody with dementia or Alzheimer's, or some of the movement disorders. It really just depends on the diagnosis, but it can be very isolating. And sometimes you feel like you don't have any choice in providing the care. We work with a lot of caregivers that are saying, nobody else is stepping up in the family, or even based on their cultural roles, it may be their, you know, responsibility to care for the older adult. And so, that's kind of one of those things where I have to do it or I'm supposed to do it, but maybe they're not really even quite ready for doing it. And of course, caregivers of homebound adults are reporting a higher rate of socialization. And then if there's, with the increase of years, again, it's just tougher because many caregivers are working, and they're also trying to juggle care for themselves. And based on the care they're providing, it's really difficult then to just go out and, meet with friends or, do things for yourself. The time just isn't there. Your time is very limited. Additionally, caregiving disproportionately impacts underserved communities. I'm sure this isn't going to be a surprising view for any of you, to see this, but highest prevalence of caregiving is 21% among non-white Hispanic caregivers. Highest burden is reported by African American caregivers by type and hours. And then for the LGBTQ plus community, there's a 2 times more likelihood of becoming a caregiver. And a lot of the information is based on there's sometimes not a congenial relationship with their blood relatives. So family of choice becomes, really their family. And so then the rate of caregiving goes up because of that, because you don't have that larger group of, siblings and such that may be supporting care of an older adult. And then Asian Americans report the greatest decline in self-rated caregiver health over 5 years. So just kind of important to really, as we all do, always look at, what is intersecting for that caregiver and, what's happening for them and how does their cultural background kind of impact their role as a caregiver. So in healthcare, we're not asking if caregivers are ready, willing, and able. We're not asking them how they're doing. We're not asking what they need to provide the care for their older adults. I think things are improving somewhat, of course, more recently, but according to this statistic, less than a third of family caregivers say that a member of the care team has really asked them, what do you need to support this older adult that you're caring for? And even less of a percentage are asking what that caregiver needs to care for themselves. So the caregivers have kind of been seen as like those invisible patients. They're kind of there, they're present. We rely on them heavily, but we're not really engaging with them. And there's a lot of reasons for that. The healthcare system wasn't really set up for that. The patient is who we're, working with. And obviously we do interact with family members, but it's basically in a limited way, in the provision of care for that older adult, and not really on their well-being, or even in a very integrated way. So Rush developed the Caring for Caregivers model, and we had two overarching goals when we developed this model. And the first one was really to address how caregivers are identified within the healthcare system. And really this meant kind of a system change, right? Because we're not identifying caregivers, that wasn't historically what was happening, so that's the starting point, of course, identifying them, really seeing them, noticing them, being aware of them. And then also formalizing that by entering that information into the electronic health record. And of course, we would like to take that further. We want them to be an integral part of the healthcare team, but it starts with identification and recognition. Our second goal was then to provide direct services and supports for those family caregivers that really bolster their physical and emotional health and well-being. So literature, and of course, as we're developing our model, we of course looked at literature and wanted to make sure we were, going to be applying best practices. And, literature kind of tells us that both psychotherapeutic and psychoeducational interventions have the most consistent realized effects for caregiver outcomes. Additionally, being aware, as I kind of mentioned, there's a lot of factors, that impact, those outcomes. And, you have to kind of think about the relationship between the caregiver and the care recipient. Gender comes into play often, looking at what their baseline of burden is, what else is going on for them. All those pieces come into play. And I'll talk a little bit more about, relationship and family dynamics in a bit as well, and how challenging they can be for a lot of our caregivers. And also, of course, the diagnosis of that care recipient can be very impactful. So we know that there's additional stressors associated with dementia caregiving because of the inconsistencies and some of the behaviors, and then just the significant loss that occurs, the anticipatory grief and loss that occurs, like kind of on an ongoing basis, as you see that person really declining with that particular diagnosis. So Caring for Caregivers is based on the 4 M's of an age-friendly system. And I know you're aware of those 4 M's of what matters: medication, mentation, and mobility. So our model is based on that 4 M's, and we actually look at the 4 M's both for the caregiver and the older adult. And then our model also supports compliance with the Caregiver Advisory Court Enable Act, the CARE Act. And of course, your state is one of those that is, just like my state, Illinois, has that state law in place. And I'll talk a little bit about that in a second on what those requirements are. The interesting thing about the CARE Act, though, it's been enacted probably, I think it started 2016 or so when it kind of started, then states kind of started implementing or adopting that law. The issue is there's no governing body that comes in and monitors or checks on compliance with that, right? So it's kind of like we're kind of on our own, like the honor system, to be doing this. So that tends to, when somebody's not coming in and checking, and, there's nothing punitive about not complying, it gets a little tricky, and it leaves that door open for, maybe not doing it in the most robust way. But this model actually really supports an easy way to really comply with that and be ready for that when there might be some follow-up on that state law. Our model is also person-centered. It's a very individualized approach to working with caregivers. It was designed to be delivered in both medical and community-based settings, and we really learned a lot in our pilot testing with those 6 age-friendly health systems. And one of those things that we learned was, of course, we think about healthcare, there's just so much diversity around healthcare based on the community, the population served. It's in the setting urban or rural. all those kind of factors, resources of that, health system, et cetera. So it really needed to be, we felt our model had to be really adaptable in its implementation to be able to fit the needs of that particular community and, of course, the resources of that health center. We're also in alignment with value-based care, and the model is sustainable, which we know that's important. Does it make sense to be able to put a program in place, no matter what the outcomes are, if you can sustain it and keep it going? And we're sustainable through billing using established psychotherapy codes and the new CMS codes, and I'll certainly talk about that as well. So this is just that little bit about the CARE Act, and just to kind of remind you, if you're not real familiar with it, these are the 3 requirements for hospitals, and this is, of course, inpatient setting. But the care recipient, so the older adult or care recipient that is in the hospital, is supposed to be asked if they have a caregiver, if they'd like to identify a caregiver, and then that person is supposed to be recorded in the electronic health record. The second one is that the caregiver is supposed to be identified about impending discharge, which we're assuming that's probably happening pretty consistently, that there's, engagement with that and letting that next person know what's going on with discharge and the discharge plan. But that third component, if you look at that, the caregiver is supposed to be offered training on the skills that they need to have to provide the care once that person returns home. So we know that that's what's the likelihood that that's happening across the board in hospitals that are under the CARE Act. So that's also where those new caregiver training service codes come in to support some of this. And I'll talk about that as well in a little more depth. So just a quick shot of how we identify and document caregivers in our system at Rush. This is the Epic system. I don't know what your system is, but many of us are using the Epic system. So how we got this was a build, of course, and we had to go to our IT folks to get this done. And how we accomplished that, because I'm sure you're the same, if you're trying to get something built into Epic
That's a cute idea.
through your
Oops.
IT through your IT group, it can be quite daunting, and you might be on the waiting list for months before your need gets addressed, because there's a long list of things that come before. But we went to our compliance officer and talked about the CARE Act and said, well, we want to be in compliance, and this is a way to do it. And so this really got pushed through, and we kind of developed this fairly quickly. And so the great thing about how this was built was, you open the chart, you see the storyboard, and if there's an identified caregiver, it's very clear and visible right up in that nice storyboard. So in that kind of vital information, caregivers right up there. And then if you hover over that field, it'll take you to where that information lives, if you will, and it's in the supportive care team, which kind of also, solidifies that the caregiver is part of the supportive care team for this patient, for Abe, right? And then within that, there's a lot of opportunity for additional information. So of course, contact information, but also clarification. Are they the healthcare power of attorney? Are they a guardian for that person? So some of that information that's really important to know and find very quickly and very easily across all levels of care within a health system. So this can be seen by anyone that opens the chart and accessed. So that's one way to identify caregivers, right? To have a systematic way of in a designated spot where it's clearly identified who the caregiver is and how to find that information. But how do you get there? So how do you, caregivers are coming through the system, and how do you even identify them other than in that inpatient setting? How do you do it on an outpatient setting? And kind of really consistently try and get those caregivers identified and entered. So several of the things that we're doing, and these are the suggestions we have for others, is coming up with a couple of questions that don't use the word caregiver, though, because, we have caregiver questions, but we don't want to really have that labeled in the question, because many don't identify with that term caregiver, right? I'm not a caregiver. This is my mom, so I'm the daughter, and, they're not even thinking about the caregivers per se. And then culturally, it often doesn't translate. For some cultures, that word caregiver, it's meaningless. It doesn't resonate at all. So we really just want to get into are you responsible, or you're assisting someone for, with care, and then you kind of list some of those things, medical care, household needs, because sometimes they think I'm not really a caregiver unless I'm living there or providing intense medical care, but really any of these things can denote that you're providing care for an older adult. So there's several ways you can do it, and several ways that we do it. You could include it in your kind of part of your interaction with your patients. So if there's somebody there, you could ask the patient, are they responsible? Because sometimes your patient is also a caregiver. So certainly, with my primary doctor, I was always talking about how the care I provided, was impacting my health and well-being. But you can also ask the older adult, do you have somebody that's helping you or supporting you with some of these things? You can also add these questions to social determinants of health screening, which is also, really generally kind of provided in health systems. And we also included in our Medicare annual wellness visit template. So engaging caregivers, again, it varies from setting to setting. We are continually kind of connecting with our providers across the system, and it's okay to engage with caregivers. It can just take a moment or two to engage with them, and the impact that will have can be really important, and will just being recognized is really, I mean, this is the feedback we're getting from caregivers, that they just want to be recognized and noticed as part of the team, and they have a value add. I often had to really be very vocal when I was accompanying my mom to her appointments, or my dad, to be able to provide my observations. I mean, I lived with my parents, so I was really seeing changes and things that were happening, that I could report back, and it was a rich part of the information that I feel providers could use as they were kind of assessing what was going on and supporting the health of my parents. So, caregivers are looking for that connection and being seen. So when we engage with caregivers, we really use a strength-based approach. So we want to really kind of acknowledge, and explore, when we work with them directly, meaning our caring for caregivers teams, the meaning and purpose behind what they're doing, kind of looking at those cultural obligations and responsibilities, obviously, noting any intersectional identities, intergenerational impact, and then just that whole person care, and just kind of really looking at it very holistically when we're working with caregivers. It's such important information if we were to provide the appropriate intervention and support for them. So these are just a few things. I won't go through them, but I wanted to make sure we included them in the slides. I mean, as I'm a licensed clinical social worker, my team are all clinical social workers. And so we're very familiar with active listening and reflective listening. That's what we do on a regular basis. And so it's just so important, though, when you're working with caregivers, to really use these active listening skills, or, as I'm sure you're familiar with these, just those open-ended questions. I've given a couple examples here, validating so that, someone feels like that you've heard them, and then reflecting back to make sure, am I understanding what they're really trying to say here? And that can just go a long way when you do that kind of active listening. They're going to feel heard, they're going to feel involved, they're going to feel more supported as they're providing care for your patient. So in our model, we've identified caregivers. I showed you how we kind of identify them with, across the system by social determinants of health screening, Medicare annual wellness visit, and some of our providers are just kind of engaging with them in their interactions with their patients. And so we get a lot of referrals just across our health system from all areas, inpatient, outpatient, as well as in the community. And then we get some self-referrals from caregivers, that word of mouth, they hear about us, and then they self-refer to our program. And our beginning point with our caregivers, once we receive a referral from wherever it comes from, is what we call a getting to know you meeting. So it's a conversation. We do not want to, use that word assessment when we're working with caregivers, because, nobody really wants to be assessed. and picked apart and like, investigated, so to speak. So we're really wanting to get to know what their situation is. They want to know, we want to know what's happening for them, what their stressors are, what their strengths are, what their role is. Are they living close by? Are they driving an hour? Are they an hour away from the person they're caring for? Do they live there? What the relationship is like. Now, certainly, this doesn't all happen in maybe that first conversation, but that first conversation is that reflective listening, that active and reflective listening, so that they know they're being heard. We understand and hear them. So it's kind of trying to start building that therapeutic relationship, right? We have a program that's just for caregivers. This is for you, and this is why we're here. And oftentimes we get a reaction from caregivers because they're just thinking like, oh my gosh, there's an actual full program just for caregivers. They're just kind of amazed at that. And I'm very encouraged. So in addition to our conversation, or a part of that conversation, we are assessing using evidence-based screeners as well, because we do want full information and we want to be able to really fine-tune the intervention with each caregiver individually. So we use the PHQ for our depressive symptoms, the GAD-7 for anxiety. We use the burden scale for family caregivers. I'm going to show you that in a second. We also do the brief health literacy screener because we really want to get a sense of where their health literacy is so we can support that and enhance that for them and just continue to build on that. Obviously, we do social determinants of health screening, and then we do a full biopsychosocial spiritual assessment. That often comes in a further conversation, but these are the assessments that we do with the caregivers. This is a shot of the burden scale because a lot of folks are not familiar with this particular scale. The Zarit is more commonly utilized, and it certainly is utilized. We use it we are guide model participants, so we use that for our caregivers that are going through that program. But for all of our other caregivers, we use the burden scale. And the reason is we like this one. It's a short screener. It also doesn't use the word relative. So the Zarit uses that word relative, and not everybody's caring for a relative. In fact, quite a few folks are not. It's a friend, it's family of choice, etc. So we appreciated that. And also the Zarit doesn't ask that financial question. And so that number 5, which is really kind of a big factor for many caregivers, their financial situation is often impacted. So we appreciate these questions. And we see it as similar to the Zarit, though it does kind of hone in on that caregiver role and helps with self-identification for many caregivers. So if they're not even identifying as providing care to a certain degree, this often kind of just connects with, I am having some impact. I am doing some of this care. Maybe even I am a caregiver. And we'll often get maybe an emotional response from some of these questions because they're quite, introspective, and kind of, sometimes I don't really feel like myself. Time to time, I wish I could run away from the situation I am in. These are tough questions, but it really kind of gets to, where they're at. And it's a really useful tool. We had a lot of success with this, and we've had a lot of feedback from our caregivers, how much they appreciated these questions. So we've identified our caregivers. We've worked to understand them by assessment and conversation, and now we want to assist them. So based on those identified needs, with that conversation, the assessments, and just really hearing what's going on for them, we offer these various components of intervention, along with, of course, connecting to any potential resources that, as we're talking with them, may come up as a source of support. And I'll talk about that in a little bit too. So I'm going to start over to the left with skill building. So the skill building is, we built this into our model because similar to what the CARE Act is kind of asking us to do, provide training and support in the care that they're supposed to provide. This was our way of trying to kind of support that to a certain degree, the best we could. So a lot of this is referrals to other providers. And for instance, I'll give an example. If a caregiver reports that they are responsible for kind of supporting their person they're caring for with their mobility. So maybe in and out of wheelchair, they're in and out of bed, all those kinds of things, really just, kind of having to do lifting and lift assists and everything else. They may have reported to us that it's been very difficult. They feel like they may have, strained their back, or, they just feel like they're, not able to continue to do it. It might be a referral for PT evaluation or perhaps OT evaluation. So it's really kind of referrals at this point. However, those new caregiver training service codes have now opened up the door for additional, and that's the way we are now going to be able to connect and actually further support skill building for our caregivers. That middle component is kind of the heart of our model because it's the one that's really the most utilized by caregivers that come through our program. And it's called planning for what matters. So of course you see the one of the four M's is kind of at the heart of that. And these are brief psychotherapy sessions. So it's between 1 and 5 sessions generally, but we extend that as needed based on the needs of that particular caregiver. And really what we're doing is it's very individualized. So they may need to talk really about the family dynamics. I mean, that comes up quite a bit. It's a very common challenge for a lot of our caregivers, that just dealing with family dynamics and different opinions and feedback and just all kinds of things go on with family dynamics. And some of them can be, really quite stressful in themselves. Sometimes it's the relationship between the care receiver and caregiver. Maybe it's been historically a very challenging relationship, and now this person is finding themselves in the role of caring for this person that's been very difficult, maybe their entire life, etc. So it really depends. But also in that is usually, current planning, like what's the plan now for providing care, as well as taking care of yourself, like how to manage that and monitor that and kind of create this plan that really works based on what matters. And then also future planning based on needs. And then I'll just finish with this one, and then I'll just stop to see if I should break for questions or if anybody has any concerns at this point that they'd like to address. But our third component is care team planning meetings. Really what that is within a healthcare setting is a goals of care meeting. So really just that opportunity to engage the full care team to really ensure that everybody's on the same page, primary, specialty, home health if they're involved, and of course the dyad, and really honing in on making sure that what matters is at the heart of their care plan, because sometimes that's not quite where it's at. So really making sure, and that's usually if we hear from the caregiver or the care recipient, because we can work with the dyad, if they're feeling like there's some conflict among their providers, or they're unsure if the plan is kind of meeting their what matters and what's important to them. And then we'll arrange for this care team planning meeting. So I'm going to stop for a minute because I've been kind of just, talking and talking. Just wanted to see if there were any questions or concerns at this point that I can address or answer.
There was one question in the chat. Are you able to hear me okay?
Yes.
Great. With the assessments that you've been talking about, including this, where does this live? Where does this information live once it's gathered? How could other people find it?
That's a great question. And I probably should have said that right along with it. So most of the time we're working with the caregiver particularly, so we can work with the dyad. We have done that, but I would say the higher percentage, the caregiver is really looking for their own form of support and often not really wanting their care recipient to know that they're burdened or exhausted or having trouble with all the other family members, etc. So we work usually just with the caregiver. And so we recorded the caregiver's chart. And if they don't have a chart, because we also work with folks, they do not have to receive medical care at Rush to be involved in our program. If they're not already a patient of Rush, we open a chart for them. We create a chart. And so, we get all their information, insurance, etc., because we do bill insurance for our services. And we get all that information, and that's where we record that information. Okay. All right, I will continue. So once we've identified, understood, and then, provided that very individualized intervention for their caregiver. And let me mention too that that also can include resources. So sometimes a support group would be recommended for that caregiver, or they ask about that, and we can provide that information. Maybe it's respite care, maybe it's something particularly for the older adult, like a Meals on Wheels, or other financial support, some of those social determinants of health kind of supports. So we have, always an updated list of what resources are available. And so we also provide those as needed based, as a part of their intervention plan. So once a caregiver has completed their intervention, we then follow up with them at 1, 3, and 6 months. I will say though, we've kind of stopped doing 6 months more recently. So, but I wanted to have show you the data that we had. So we do follow up with them, and we rescreen for that burden using the burden scale, the PHQ, and the GAD. So we're screening for those. And as you can see, we do see reductions in all 3 areas over time. The other thing about following up, of course, is we're reconnecting with that caregiver, checking to see, are there any new needs? Is there something that has changed that we can provide additional support or resources around? So it's kind of a check-in, and then always just kind of letting them know, we're here for you. You can always re-engage with us at any time, which is part of the program too. They can re-engage if they feel they need additional support. Additionally, we wanted to take a look to see how we might be impacting the care recipients. So we basically, for those care recipients that were receiving their care rush, we took a look at their utilization of the hospital 6 months prior to their caregiver receiving our intervention and 6 months post-intervention. And as you can see here, we saw significant reductions in inpatient days, stays, and ED visits. And although, of course, we don't claim causality because we didn't do that kind of a, analysis, we just saw it as a promising look at if we're caring for that caregiver and really supporting their well-being, their emotional health, and their confidence level in the care that they're providing, and their understanding of the disease, etc., and some of the symptoms, whatever that looks like for them, the likelihood of these numbers coming down is pretty likely. So we saw this as a very promising piece of information. So I mentioned earlier that the model is adaptable and it's sustainable. So we talk to many sites across the country every week about the model, and kind of go through, really how many ways it can be implemented. And so, we just really work one-on-one. We kind of find out what their resources are, and then we kind of chat that out and talk about some of the ways they can really implement the model. We also very much encourage, of course, collaborating with local area agencies on aging and other community-based organizations. It's just really, collaboration, and you're just going to have a more robust system of support if you're doing it that way. We use our area agency on aging. I mean, we're very collaborative with them. We're constantly referring to them. They're referring people to us. So it's really, it's just the way to go, because we're just reaching so many more people that way, based on the fact that we're willing to kind of really put effort into collaboration. So the services can be billed as part of your usual service line. Now, I say that because in some cases, like I'll give an example, in our cancer center, they actually have our model embedded in their clinic, in their supportive oncology clinic. So they provide that as part of their usual service line, as like an additional support for their patients. We bill through psychotherapy, through insurance, and I just kind of noticed some of the codes there. But also we recommend, if a hospital doesn't have like clinical folks available to provide those services like we do, licensed clinical social workers, that you could technically work with a community clinic to offer these services, because we would train then that clinic as well as the hospital team to implement the model. I mentioned those caregiver training service codes. You're probably aware of these, but I like to just kind of give you the visual on these as well. Because we have not yet implemented these, but we're doing all the back end work of getting all the coding in and the documentation prepared, etc. So I'm assuming in the next couple of months we'll start our implementation of these codes. And there's a multiple versions of them. It's behavior training. There's also skill building training around activities of daily living and IADLs as well. So this is part of that skill building piece that I was talking about, which will enhance then the caregivers' competence and the skills that they have for care. So kind of wrapping up here a bit, just to let you know, we do train on the model. It's at no cost to any of the health systems that we work with. So we offer full training. We have educational materials to assist with implementation, and we offer technical assistance as well throughout implementation. These are those manuals that we offer as part of our training. So we have one that's specifically for the clinicians that are going to be doing the model. We have one for administrators as well. Some of the same information, but it kind of hones in on the business case and why it's important to support caregivers. We also have a manual on our planning for what matters sessions. Those are those brief psychotherapy sessions. It's really just a guide though for clinicians because of course these are individualized sessions and they vary from caregiver to caregiver. But this just kind of captures really a lot of the common elements that we see with caregiving. So it's kind of that guide for that clinician to be able to utilize that. And then we have a workbook for the caregiver that has it's theirs to have, and it's just got space for them to write things and keep things noted. And then some of the tools that we use as we're providing support to them. And then I wanted to make sure I included some sources of assistance because we have some of our settings that aren't quite ready yet to implement the full model, but they are working on identification and assessment, and then they want to have some resources to provide for their caregivers. So this is generally, kind of some of the best ways to go as far as assistance. If you're not familiar with their best programs for caregiving, it's a website. This is for dementia care though, but there also are some models like ours that are noted as best programs for caregiving dementia care, but also like we support any medical condition. So runs the gamut, but we also do have a very high percentage of caregivers supporting someone with Alzheimer's or dementia. Your area agency on aging, of course, because they have a lot of things. These are just a couple of things that they have to offer. But they have a lot of support services for the dyad, for both caregivers and the older adult, of course. Support groups, and then some of those psychoeducational that are evidence-based, the stress busting and the savvy caregivers, and some of these other, care coordination is always important. And then there's a lot of tech-based interventions out there now as well for caregivers. Not sure if you're familiar with these, so I wanted to make sure I put them on there. These are really, these are videos that AARP and Rush put together. And it's really about, as you can see, preparing for a hospital stay is one of them. And then the other topics are on the side there. And so those are just available. And sometimes those are really nice. Some of our folks just really appreciate, a video or, information in this format. So that's a nice source for them as well. And then this is just, learning more about, caregiving, that we have some options there that you could learn a bit more. And I want to thank you so much for your time and attention, and also mention that I failed to put the link for the